Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. Today we are starting the Psychiatry series. And the first topic that we are going to discuss right now is the conditioning. There are two types of conditioning. We have classical and the operant conditioning. Let's start with the classical conditioning. Before we dive deep into discussing the classical versus operant conditioning, I'd like to tell you one very important thing about how to distinguish between these two types of conditioning. Classical conditioning elicits involuntary responses, something that we cannot control on our own. In contrast, the operant conditioning elicits the voluntary responses. And we'll see the examples for these actions while we go through. First, classical conditioning means that the natural response is elicited by the learned or conditioned stimulus. We have several terms when we talk about the classical conditioning. Here we have unconditioned stimulus, unconditioned response, conditioned stimulus, and conditioned response. In classical conditioning, the unconditioned and conditioned response are always the same thing, while unconditioned stimulus and the conditioned stimulus are the different things. And let me give you an example. I think the very first example that comes into everybody's mind while talking about the classical conditioning is the Pavlov's experiment with the dogs. So the sight of the food is the unconditioned stimulus for the dog to start salivating. Salivation in this case is the unconditioned response. What Pavlov did was that he rang the bell every time he brought the food to his dog. In this case, salivation in the dog was followed, salivation in the dog followed ringing the bell. So in this case, bell was presented at the same time as the food. And while the food is an unconditioned stimulus for salivation, ringing the bell became the conditioned stimulus for salivation. And then, even if Pavlov didn't bring food to the dog, just ringing the bell would elicit salivation in the dog, because the dog was expecting the food when he or she was hearing the ringing bell. In this case, ringing bell is a conditioned stimulus. It's a learned stimulus. It's learned because normally neither dogs nor human beings, no one salivates in response to ringing bell. However, if you present the ringing bell in conjunction with the food, then the dog will start salivating in response to ringing the bell. And the conditioned response in this case was also salivation in response to the ringing bell. Now, there are many, many different examples of classical conditioning, and I would like to encourage you to think about the daily moments that could be the example of classical conditioning. Let me give you my example. Several months ago, I was listening to one of the TED Talks, and the speaker was teaching the audience how to link the positive feelings with the different activities. And here is what he was saying. So he encouraged the audience to just imagine the most positive moment of their lives. And imagining the positive moment of your life definitely brings you happiness, or at least joy. In this case, the unconditioned stimulus is thinking about your positive experience, while unconditioned response is the feeling of happiness and joy in response to that positive thought, right? And then the speaker was teaching the audience how to link this happiness with some unrelated physical activities. For example, he he was saying that you can literally pinch your arm while you are thinking about this positive experience. And if you repeat this act several times, in other words, if you pinch your arm every time you think about that positive experience, then just pinching the arm will bring you this sense of joy or happiness. And that's the classical example of classical conditioning. In this case, pinching the arm is the conditioned stimulus. It's conditioned or learned because in reality it has nothing to do with the feeling of joy or happiness. But after it was presented together with the positive thought that the audience was thinking, then pinching the arm became the conditioned stimulus. So it could bring the sense of joy and happiness to the audience. There is one interesting phenomenon in classical conditioning. It's called extinction. We'll also talk about extinction while we move on to the operant conditioning. And I'm saying this here just to let you know that extinction is present in both classical and operant conditioning. In classical conditioning, extinction means uncoupling of the unconditioned and conditioned stimuli. Let's go back to the example that I told you. Example where pinching your arm was coupled with thinking about the positive experience, and therefore pinching the arm gave you the sense of joy and happiness. Now let's say that you pinch your arm several times, but during this activity you don't think about that positive experience at all. So you intentionally uncouple the unconditioned stimulus, which is thinking about the positive experience, and the conditioned stimulus, which is pinching your arm. And after several attempts, then pinching the arm will no longer give you the sense of joy or happiness because it's uncoupled from the unconditioned stimulus, and therefore it can no longer elicit the conditioned response, which is the sense of joy or happiness. The same can be extrapolated to Pavlov's experiment, right? He, as we already mentioned, presented food and rang the bell at the same time. Therefore, ringing the bell started to elicit salivation in the dogs. Now, if he would ring the bell without presenting food to the dog, then eventually the dog would no longer salivate in response to ringing the bell. Because ringing the bell, that is conditioned stimulus, would be uncoupled from food, which is unconditioned stimulus. Okay, this was classical conditioning. Now let's move on to the operant conditioning. In operant conditioning, we elicit the voluntary responses, the actions that we can consciously control. And there are two very high yield terms in the realm of operant conditioning. This is reinforcement and punishment. And reinforcement and punishment then exist in two forms. We have positive reinforcement and negative reinforcement, and then we have positive punishment and the negative punishment. Let's talk about each of these four phenomena. First of all, what is reinforcement? Could you please tell me what the reinforcement is? I hope you're telling me that the reinforcement is the action that increases the target behavior in the study object, whether it's the human being or an animal, it doesn't matter. So reinforcement is the action that increases the target behavior. Okay, now what's the difference between the positive and the negative reinforcement? Well, when we say the words positive and negative while talking about the reinforcement and punishment, the word positive means adding a stimulus, while the word negative means removing the stimulus. So when we say that observer applied the positive reinforcement to the study object, we mean that he or she added the pleasant stimulus, which increased the target behavior in the study object. Let me give you an example for this. Let's say that the mother gives an ice cream to her child every time she brings the high scores from school. This is the classic example of positive reinforcement. Giving the ice cream is certainly the reinforcement because most of the kids love ice cream, right? And not only the kids. So it increases the child's willingness to get more and more high grades so that she can get more ice cream. And at the same time, giving an ice cream is the positive reinforcement because the mother is adding a stimulus, right? So it's not removing the unpleasant stimulus, it's adding the pleasant stimulus, which in this case is an ice cream. Now let me give you an example for negative reinforcement. Let's say that the father just allows the child to miss, I don't know, the music lessons if he gets the high grades in school. That's not a good example, I know. However, what I'm trying to say here is that if the child does not love the music lessons, and if you allow him to miss the music lessons every time he gets the high grade, that's the negative reinforcement. Because missing the music lesson gives him stimulation to get more and more high grades so that he can miss more and more music lessons, right? And just allowing the person to miss that music lesson is the negative reinforcement because you take away the unpleasant stimulus. You don't add a stimulus, you take away it. And the unpleasant stimulus in this case is the music lesson. Okay, let's move on to the punishment. Punishment, on the other hand, is the action by the observer which decreases the target behavior. And just as we have the positive and negative reinforcement, we also have positive and negative punishment. And again, the meaning of the words positive and negative is the same while talking about the punishment as when we were talking about the reinforcement. So positive punishment means that you add the aversive stimulus to decrease the behavior in the study subject. Let me give you an example. If the child throws a tantrum in the public space, and if the uh, parent just tells him off and just raises his or her voice, that is the positive punishment. It's punishment because it's intended to decrease the behavior of the child, in this case tantrum, and it's positive because you add a stimulus. You add the unpleasant stimulus, which is raising your voice and be and sounding disappointed, right? Let's talk about the negative punishment. Negative punishment is when you take away the pleasant stimulus with the hope of decreasing the other person's behavior. Let's take another example. Let's say that the parents have two kids and they fight very, very commonly. If the parents prohibit using any of the electronic gadgets or prohibit the kids playing with their favorite toys after the fight, that will be the example of negative punishment. It's punishment because it's intended to decrease the behavior of fighting between the kids, and it's negative punishment because the parents remove the pleasant stimulus from the kids. And the pleasant stimulus in this case is the electronic gadget or the favorite toy or something else. And according to these two types of reinforcement and the punishment, we can build up the Skinner operant conditioning quadrants. So these are the quadrants which explain what each type of operant conditioning is. So in the vertical columns, we have reinforcement and punishment. So action that increases the behavior as the reinforcement, and the action that decreases the behavior as the punishment. And in the horizontal rows, we have adding the stimulus and removing the stimulus. Anything along the row of adding the stimulus will be positive, both positive reinforcement and the positive punishment. And anything along the row of removing the stimulus will be negative, both negative reinforcement and negative punishment. And before we move on to the next topic, let's also mention the concept of extinction in the context of the operant conditioning. Extinction in operant conditioning specifically means the discontinuation of the reinforcement and elimination of the desired behavior. Let's get back to our example where the mother gives an ice cream to her child every time she brings the high grade at home from school. Now, if that happens over a period of time, but then mother stops giving her child the ice cream for every high score at school, then the child might eventually stop getting the high scores at school because she no longer has the motivation of getting the high scores because she knows that she will no longer get the ice cream. This is the classical example of extinction. So the person was affected by the reinforcement at first, but then the reinforcement was taken away, whether it's positive reinforcement or negative reinforcement, and that caused elimination of behavior in the person. Extinction in case of operant conditioning is not the same thing as punishment. Extinction is first preceded by reinforcement, and then you remove the reinforcement, whether it's positive or negative. When we talk about the punishment, punishment is not necessarily preceded by the reinforcement. So you apply the punishment with the intention to decrease the behavior. Right? So to summarize, extinction is decrease in your target behavior by removing the reinforcement, while punishment is the attempt to decrease the target behavior by adding the punishment or by applying the punishment. Okay, I hope that the classical and operant conditioning were clear for you. And now let's move on to the next topic, which is transference and countertransference. Transference and countertransference can have very significant effect on the patient-doctor relationship, because transference and the countertransference can determine the person's attitude towards the other person, right? Transference is when the patient projects his or her feelings about the other important person onto the physician, right? Let's say that when the patient first meets the physician reminds the patient of his father or mother. And let's say that the patient does not have a good relationship with either his mother or father. In this case, the patient, will be negatively affected by the transference, and therefore his attitude towards the physician will be negative for no apparent reason. And the transference and countertransference can happen both consciously and unconsciously. When you look at the person, you may actually realize that this person reminds you of someone else who is important to you in some way, either positive way or negative way. However, the transference and countertransference can also be unconscious, when you don't realize that the person reminds you of someone, but you still feel either positive or negative feelings for some unknown reason. The countertransference is the same process as the transference, but from the standpoint of the physician. In this case, the patient reminds the physician of an important person in the physician's life. Let's say that the patient reminds the physician of her closest friend. In that case, physician will have a very, very positive attitude towards the patient with no apparent reason. Even if the patient doesn't speak first, just looking at the patient may give the physician the positive feelings about that patient. And you can realize that transference and countertransference can bias our relationship, and therefore it's very beneficial to be mindful of the transference and the countertransference. And if the patient has negative attitude towards the physician, it's always helpful to ask the reason why. Because sometimes even the patient may not know why she or he has the negative feelings towards the physician. And uncovering the transference and the countertransference can unbias the doctor-patient relationship and can help the physician to achieve the best possible healthcare for the patient. Okay, the transference and countertransference was a small topic apparently, and now we'll move on to ego defenses. The ego defenses, also known as the defense mechanisms, are our thoughts or the actions which prevent us from feeling anxious or depressed. These are the thoughts or the feeling, or thoughts or the behaviors, the actions which just prevent us from feeling the negative emotions. And the defense mechanisms can be both voluntary or involuntary and unconscious. There are several different ways to classify the defense mechanisms, but the most important the easiest and probably the highest dosed way of classifying these defenses is into the immature defenses and the mature ego defenses. There are only four mature ego defenses. All the other ones are immature defenses. And since the group of immature defenses is vast, we'll start with the immature defense mechanisms. The first defense mechanism that I'd like to talk to you about is the acting out. Acting out can mean two different things. When the person is having the negative feelings, he or she may act these feelings out. He or she may act these feelings out by, I don't know, shouting and by yelling, by being super aggressive. That'll be acting out. But acting out can also mean that the person tries to feel some other very strong emotion that'll overcome and cover the negative emotion. For example, let's take a teenager whose parents are getting divorced, and that's a stressful event for the teenager, and then the teenager starts to engage in many risky behaviors, driving the car with a high speed, engaging in the unprotected sex. All of these actions gives him or her very strong emotions that can potentially prevent him or her from thinking about the parents' divorce. So again, acting out can mean two things. You either act your negative feelings out, or you try to get another very strong feeling which will defeat or make you forget your negative feeling. Let's move on to the denial. And denial is also what it says. The person denies something painful and something very serious in their lives. Denial is the normal phase of the grief reaction. And if you remember, the grief reaction is divided into 5 different stages, right? According to the Kubler-Ross system. And the first stage there is denial. This is when the person does not believe that something bad is going to happen or is happening in her or his life. Let's say that the physician informs the patient that the patient has cancer and survival from this cancer is very low. And then the patient goes like, "Doc, that must be a mistake. You probably messed up somebody else's lab reports with my lab reports." These words are the classic example of denial. By these words, the patient is telling you that he or she does not want to believe that something that serious as cancer is happening to him or her. Okay, let's move on to displacement. Displacement is when you displace your feelings from the person that elicited the feelings to the neutral person. And that is very different from projection. We'll discuss projection after we're done with the displacement. However, first let me give you an example of displacement. Let's say that the person, like the employer, gets yelled at by his boss in his office. And then that person comes home and yells at her daughter for not doing her homework. Then daughter yells at their dog for, I don't know, for something. So what I'm trying to tell you is that displacement usually follows the hierarchy. you displace your feelings towards the neutral person that you know that you can express your feelings to. For example, you are a little hesitant to express your negative feelings to your boss, but then you know that you can express your feelings to your family member. So that's displacement. Now, what is projection? Projection is when you project your own negative or undesired feelings onto another person. Let's say that the wife wants to cheat on her husband or is cheating on her husband, and then the wife is blaming the husband for cheating on her while the husband is actually not cheating on her. In this case, the wife projects her undesirable and negative feelings onto the husband. So by believing that the husband is cheating on her, she feels relieved and she doesn't think low of herself. That's the projection. Okay? Right. We are done with the projection as well. And now let's move on to dissociation. Dissociation is when the person dissociates his mind from his body. And this usually happens after abuse victims or trauma victims. These patients experience change in their personality, change in their consciousness, and derealization while they are reminded of their painful experience. And the classic example that the first aid usually gives is that a survivor of the sexual abuse feels numb and feels detached while he or she sees the abuser. In that case, the patient dissociates his mind and his feelings from his body because he or she doesn't want to deal with that painful experience anymore. Right. Let's move on to the fixation. Fixation means that the person is fixated at some point to the childish behavior. So this is when the person partially remains at more childish level of the development, and this is very different from regression. Fixation is a permanent thing. So what I'm trying to say is that the person is constantly at the level of childish behavior. I mean, it may not be evident all the time, however, is always there with the person. And please don't get me wrong. When we say fixation, we don't mean that the person is at the childish level of mental and intellectual development. That's totally wrong. We're saying that the person with fixation expresses his or her feelings in a more childish way than the adult way. And the classic example here is when the physician throws a tantrum in the clinic because he or she didn't like something, didn't like how the resident worked or how the intern worked. Throwing a tantrum is more or less childish way of dealing with a difficult situation. And if throwing tantrum repeats over and over, then we can say that it's a fixation. Okay, now what is regression? Regression is when the patient regresses to behaving in a childish way, but that's temporary thing. So regression, in contrast to fixation, is not permanent. That's temporary. For example, let's say that the patient, let's say 25-year-old man, is diagnosed with leukemia or some other serious diagnosis, and then he starts talking like a child to his parents so that he can get as much affection and love as he used to get when he was a child. So in this case, we try to behave in a childish way because we want to be treated like children. So children are treated with much love, at least they should be treated with much love and affection, and we want to feel the same love and affection when we feel insecure. This is the regression. Okay, we have already talked about the regression as well, regression and fixation. And the next defense mechanism that I'd like to discuss with you is the idealization. And the word here says everything that we need to know. Idealization is when the person idealizes someone else because the person cannot stand the ambiguous thoughts about another person. For example, let's say that the girlfriend adores his boyfriend in a way that she totally ignores the negative sides of his boyfriend. In this case, that can be interpreted as idealization, because if you just refuse to accept the negative sides of another person, it means that you cannot tolerate the ambiguous feeling about the other person. So the person that you are with needs to be perfect, and that's why you are idealizing him or her. Okay, idealization is totally different than splitting. Splitting is when you split the people into good or bad, kind and evil, white and black. So these are people. Splitting is usually used by the patients who have the borderline personality disorder. And the reason for this is that patients with borderline personality disorder cannot tolerate ambiguity about the other person. For them, the person should be either completely good, perfect, an angel, or completely bad and devil. But we know that that's simply not the reality, right? So none of the people is either truly an angel or a devil. There's a gray area. All of us have our positive sides and all of us have our negative sides. But when the person uses splitting as his or her defense mechanism, for him, the person A is an angel and the person B is the devil. And even more, the person who uses splitting as the defense mechanism can actually switch his or her attitude towards the people. So if on one day the person A was an angel and person B was a devil, then on the other day the person A might become a devil while the person B might become an angel. And again, splitting is very common in patients with borderline personality disorder. Right. So we have talked about the splitting and idealization, and now let's move on to identification or introjection. Identification is when you identify, mostly unconsciously, with the person that is strong and powerful in your eyes. And identification can end up identification can be positive or negative. For example, if your boss is the perfect leader and then you unconsciously identify with her or him, that's certainly a positive identification, because this helps you to progress as an individual. However, identification can be negative and dangerous as well. Let's say that the person was abused as a child, and when somebody is abused, then that person feels insecure during the act of abuse, and he or she sees the abuser as someone who is strong and in some cases even authoritative in their eyes, which means that the abused children may become abusers in the future. So they identify themselves with their abuser so that they feel powerful and strong. Okay, the next defense mechanism is the isolation of affect. Isolation of affect is when you isolate your feelings from the events that are happening to you. Before we dive deep into this defense mechanism, let me tell you what the difference is between the mood and the affect. The mood is the internal state of the person. Mood is how you feel internally, while the affect is the external expression of the mood. In other words, the affect is how you express your mood. And the mood and the affect are not always congruent. The person may be sad or even depressed, but the person may be laughing. So if the person acts happy and acts confident and acts okay, that doesn't mean that the person is really okay. And the mood and the affect can be incongruent in the opposite way as well. For example, the patient may be feeling happiness inside, but he or she may not be expressing that feeling. So he or she may be may seem normal, not agitated and not excited due to their inner feelings. Okay, now let's get back to the isolation of affect. This is when you try to think about your own negative experiences as if they are of someone else's experience. Let me give you an example, and this will become very clear for you. Let's say that the teenager has just found out that she or he is adopted. And then the teenager shares his or her story with her friend. And when the teenager talks about the adoption, she's talking about it as if she was talking about the third person. So she's not expressing any feelings. She's just saying the facts. So in that case, the person tries to defend himself or herself from the painful feelings that the negative events can bring on in their lives. Okay, let's move on to passive aggression. Passive aggression means that you are passively aggressive towards someone else. So you just express your hostility and your aggression by doing nothing. We probably all know our classmate who has not given the preparation, those preparation concepts to the other people. In that way, this person acts as a passive aggressive person, right? So he doesn't want other people to be ahead of him in the class or in the professional field, and that's why he doesn't want to help the other people. And that's not the only definition or only example of the passive aggression. Passive aggression can exist in many, many different ways. For example, if you are upset with a person, and if you don't talk to that person because you're upset, that can also be interpreted as passive aggression, because you want to make them realize that you're upset by not talking to them. So by being passively aggressive. Okay, now let's talk about the intellectualization, and let's contrast the intellectualization to the rationalization. Intellectualization is when you just burden your mind with all the data and all the information, sometimes the scientific information, in order to get away with your painful feelings. Let's say that the person was diagnosed with cancer, and then this person spends days and nights in the library or in front of the computer to search everything about his or her diagnosis. In this case, this person tries to get away from the painful reality, not the reality, but painful feelings, by overwhelming themselves with the pure factual information. And that's intellectualization. But what about the rationalization? Rationalization is not by any means the same as intellectualization. Rationalization is when you justify your actions that you think were wrong. For example, let's say that you failed an exam, and then you come out of the exam and you say that the questions were not fair. The questions did not reflect the the content that was discussed during the classes. Well, this might actually be true. Maybe the questions were really inadequate. However, if there's only one or two people who think like this and all the other students successfully pass the exam, then this example is probably that of rationalization. So you justify why you failed. You justify the action that was wrong or that gives you an anxiety. That's the rationalization, to come up with some justifying reasons for your actions. We have two more defense mechanisms left in the immature defense mechanism group. This is reaction formation and repression. Reaction formation, simply saying, is doing the exact opposite of what you feel. For example, let's say that in the kindergarten, the boy likes the girl, but then he feels like it's inappropriate to express the sympathy, express the positive feelings towards the girl, right? And then he tries to bother the girl in any way, and that can be interpreted as the reaction formation. Or let's say that the stepfather does not have a truly close relationship with his stepdaughter, and then he behaves like he treats the daughter with much love and affection, and he takes care of the daughter, although he in reality does not care. So in this case, we try to replace our feelings with the actions that prove the opposite, because we don't want to be caught by other people in our feelings, right? Okay, and then repression is when you involuntarily repress or forget some painful episode of your life. Let's say that, again, the teenager has the parents who are undergoing divorce, and then this teenager comes to you several years later, and then she or he tells you that they don't remember the period of divorce of their parents. In this case, they unconsciously and involuntarily repressed this episode of their lives in order not to feel the pain of their parents divorcing. And repression is absolutely different from suppression. Since we now started talking about suppression, Let's move on to the mature defenses, okay? Before we talk about suppression, let me tell you which defense mechanisms are mature defense mechanisms. This is sublimation, altruism, suppression, and the humor. The way you can remember these four ego defenses as the mature defenses is by the mnemonic that goes like this. Mature adults wear a sash. In the word sash, each letter is the first letter of each mature ego defenses, right? So S for sublimation, A for altruism, the second S for suppression, and H for humor. Since we were talking about repression, let's compare repression with suppression first. Suppression is voluntary, intentionally forgetting the painful or anxiety provoking episode of your life. And therefore, it is temporary. Repression is permanent while suppression is temporary. What I mean here is that if the person who applied suppression to his painful episode of life is reminded of that episode, he or she will remember the episode. Forgetting about that painful event of the life is just temporary, but repression is permanent. Since the person has not made any conscious effort to forget about that painful experience, then even if you confront them with the proof that they had this painful experience, they won't remember. Okay, like the example for suppression is when, let's say, you have an upcoming exam and you try to and you tell yourself not to think about the exam and to think about something else so that you don't feel anxious. That's suppression. Now that we're done with contrasting repression to suppression, let's talk about the sublimation. Sublimation is when you express the socially unacceptable wishes and feelings in a socially acceptable way. Let's say that the teenager feels aggression and resentment towards his parents, but then he channels all of that aggression and resentment into sports, and he becomes an excellent wrestler or boxer. Another example for sublimation will be when the mentor or the boss suggests the employee to spend more working hours with them and discussing their work, when in reality the mentor or the employee is intimately attracted uh, the boss or employer is intimately attracted to the employee. That is also the example of sublimation. Right. Now, what is altruism? Well, altruism is when you express the generosity to alleviate your negative feelings. In this case, the person thinks low of himself or herself, and then he or she expresses generosity towards other people, for example, by giving away his or her own money to feel gratification and to forget about his low self-esteem or like painful feelings. And altruism is different from reaction formation. Like if you act generously, if you give away your money to other people, let's say poor people, because you are internally very greedy and you don't want to be caught in that greediness, then that's reaction formation. However, if you act generously and give away your funds to other poor people because you think low of yourself due to some other reason, that's the altruism. Okay, and then the final defense mechanism, which is the mature defense mechanism, is the humor. And I think it doesn't need that much explanation. Humor is when we lightheartedly express some awkward or anxiety provoking part of the reality. The classic example is when the person jokes about her or his nose and the size of the nose when he or she knows that the nose is very big, right? In that case, the person tries to apply humor to his big nose, right? Or let's say that we have the medical student who is about to take the board exams, and then that medical student jokes a lot about what is going to happen on the board exams. That's also the humor as the mature defense mechanism. Right. Now that we have covered the defense mechanisms, let's move on to grief. Grief is the normal reaction that we experience when we lose the significant other, when we lose somebody that we love, right? For example, the family member, the spouse, the friend, and etc. Now, there are 5 different stages of grief according to the Kubler-Ross grief model. Let's list those 5 stages and let's go through each of them. The first one is denial, and we actually have already talked about denial. This is when a person doesn't believe that something traumatic has happened in his or her life. For example, if you break the bad news to the patient or to the patient's relative and say that the patient has passed away, then the family members and the relatives may deny and may ask you to recheck what you're saying, right? That's denial. After denial, there is anger. And again, this is when you're angry with the whole world and you're angry with people who have nothing to do with what you're feeling. And that's also normal. So if the patient has passed away, then the family members or the relatives may blame the physician for not doing enough to save the patient. While this might be true, this blaming behavior can also be interpreted as the anger of the Kubler-Ross grief stages. After anger, we have the bargaining. So bargaining is when you bargain with God to make your loved person come back, and you'll do anything for that. After bargaining, there comes depression, when you feel depressed and sad, and then finally there's acceptance. When you finally accept the reality and accept the fact that your loved person has gone forever. That's acceptance. The important thing about the 5 stages of grief is that they can occur in any order. It's not necessary for the person to first feel the denial and then anger and then bargaining. These 5 stages can occur literally in any order. And even more, the person doesn't necessarily have to experience all the 5 stages. The person may only experience 3 or 4 or 2 out of these 5 stages. So it's variable from one person to another. And the other symptoms that may accompany the grief is the shock from the news that the person has been informed about. Also, there might be a guilt. So the person might think that he or she did not do enough for his or her loved one. And there might also be somatic symptoms like headache or fatigue, which cannot be explained by other conditions better than they are explained with the grief. And important thing is that symptoms of grief come in waves. Whenever the patient, not the patient, but whenever the person is reminded of the deceased loved one, this is when the symptoms strike back. For example, at the anniversaries, at the birthdays of the deceased person. Even when the family member looks at the family photo, this might bring about those grief symptoms. And grief, duration of grief varies widely. Normally, it should not last more than a year, more than 12 months. If grief lasts more than 12 months and if it interferes significantly with person's functioning ability, then this is called persistent complex bereavement disorder, or PCBD. PCBD is diagnosed when, again, grief is prolonged to more than 12 months, but the patient does not meet the criteria for major depressive disorder. When the grief is prolonged, before we diagnose PCBD, we should exclude the major depressive disorder. If the person does not meet the criteria for MDD that we'll talk about in the next episodes, then we can say that this is PCBD. Okay, now that we've discussed grief, let's move on to the infant and child development. Now we'll talk about the different milestones that the child should reach in the infant stage, toddler stage, and the preschool stage of the development. However, we won't be detail oriented and thorough here because we discussed the milestones in a great detail in our pediatric section for USMLE Step 2 CK. Okay, let's start. First, the child development is divided into three main domains. We have motor development, social development, and then finally verbal and cognitive development. Let's start from an infant. Infant is the child in the first 1 year of life. And let's start with the motor development of an infant, right? We know that there are several primitive reflexes which disappear at the different times during the first year. For example, Moro reflex disappears by 3 months. Moro reflex is hang on for life reflex. It's also called in this way. And this is when you suddenly just let the child go off, let the child's head go off and the upper trunk go off. And then the child first abducts and extends the arms and then draws them towards the midline. The rooting reflex, also called the nipple-seeking reflex, is disappearing at the age of 4 months. This is when you stroke the cheek of the infant and the infant turns her or his head towards that stroking finger because he or she is looking for the breast. The palmar reflex is when the infant flexes the fingers or makes a fist when you stroke their palm. And the palmar reflex disappears by 6 months. The way you can remember that palmar reflex disappears by 6 months is that the word palmar contains 6 letters. And then finally, Babinski reflex, or extensor plantar reflex, to be more accurate, disappears by 12 months. And we know that if extensor plantar reflex reappears and reemerges after 1 year of age, then this is pathological, and it is also known as Babinski sign afterwards. Okay, here we are mentioning the different times by which the child should reach a specific milestone, but let me tell you one thing. There is a time range within which the children reach these milestones. So if the child still has the rooting reflex at the age of, 4.5 months or 5 months, that's not necessarily abnormal. Every child is developing differently, and every child has his or her own trajectory of development. But if the child has not reached the milestones and he or she is already much older than the presumed time of reaching the milestone, that's when assessing the child's development becomes necessary. Okay, now let's talk about the different fine motor and gross motor actions that an infant can perform. Before that, let's remind ourselves that the gross motor actions are those activities which are done by the large muscle groups, like the arm muscles, the thigh muscles, and etc. While the fine motor movements are the movements done by the small, delicate muscles, like the muscles of the fingers. First, the child should be able to lift the head up prone approximately by the age of 1 month. Rolling and sitting down is usually achieved by the age of 6 months. Also, the crawling is achieved by 8 months, the child stands by 10 months, and then walks anywhere from 12 to 18 months. And it's very logical and understandable if you take a close look. So crawling is at 8 months. After crawling, there is standing, right? And standing happens 2 months after crawling, so 10 months. And then after standing, there is walking. And walking happens after 2 months of standing, so at 12 months or anywhere from 12 to 18 months. Then, as for the fine motor activities, the child can pass the toy from one hand to another at the age of approximately 6 months. And then the pincer grasp usually develops at the age of 10 months. We have the 3-finger pincer grasp and the 2-finger pincer grasp. 3-finger pincer grasp is when the child puts the thumb, index, and the middle finger together to lift an object up. And 3-finger pincer grasp is achieved earlier than the 2-finger pincer grasp, where only thumb and the index finger are used to take the object. Okay, and then finally, the infant, can point to the objects at the age of 12 months. Another reason why these milestones are important is that they may be used in a very clever way in the questions about the child abuse. We'll definitely talk about child abuse in this episode later on, but what I mean here is that the question may say that the mother brings, let's say, 3 months old infant, and you see the big bruise on the infant's head, and the mother says that the infant rolled over from the bed on the floor and fell off the floor, right? And if you know that the ability of rolling over and sitting is achieved by the age of 6 months, then you automatically get the sense that mother is not telling at least the whole truth, and this child may be abused. So knowing these milestones doesn't mean that you will necessarily be asked exactly at what time the milestone is achieved. They can be used very delicately and very cleverly in the questions to test your knowledge of the milestones. Okay, now let's move into the social development of an infant. The social smile is achieved by the age of 2 months. And the way I remember this is from the mnemonic, or from the advice that my friend gave me. She said that when you smile genuinely, you smile with 2 corners of your mouth, right? Therefore, social smile is achieved by the age of 2 months. Then we have stranger anxiety and separation anxiety. Could you please tell me the difference between these two? I hope you're saying that stranger anxiety is when the child starts crying when the stranger holds him or her, while separation anxiety is when the child starts crying and being anxious when she or he can no longer see the parent in the surroundings. Stranger anxiety usually starts to develop at the age of 6 months, while separation anxiety starts to develop at the age of 9 months. As for the verbal and cognitive development of an infant, the infant can already orient to the voice of the parents by the age of 4 months, and then she or he, the infant, can orient to the name and to the gestures by the age of 9 months. 9 months is also the age when the infant reaches the concept called object permanence. Could you please tell me what the object permanence is? That's absolutely true. Let's take a step back and explain it for everyone. When the child younger than 9 months, like when you give the child a toy and then you take away the toy, if the infant is less than 9 months old, then the infant thinks that the toy has disappeared. The toy no longer exists after that toy has fallen out of his or her eyesight. But at the age of 9 months, the infant obtains the sense of object permanence. So if the infant is, let's say, 10 months, you give him or her the toy and then you hide the toy, they will start looking for the toy because they understand that although the toy is no longer within their eyesight, it has not disappeared. It still exists and they need to find it. That's the object permanence. So they get the sense that the objects are permanent even if they fall out of their eyesight. And then the simple words like mama and dada usually are spoken at the age of 10 months. Now let's move on to the toddler. Toddler is the child from the age of 1 year to 3 years. And first, let's talk about the motor development. We already mentioned that the first steps are usually taken by the age of 12 months, and then climbing the stairs can happen usually at the age of 18 months. At first, the child climbs to the stairs with both feet on each step. But then, at the age of approximately 3 years, 3 to 4 years, the child can alternate the feet on the steps. Another very high yield feature that they like to test in the questions is the number of cubes stacked on top of each other. And there is actually a formula which you can remember to remember this concept. The number of cubes stacked on top of one another is equal to the age of the child in years multiplied by 3. Let me give you an example. If the child is 2 years old, then she or he should normally be able to stack 6 cubes on top of one another because 2 times 3 is 6. As for the cutlery, or the child's ability to use the fork and the spoon, that is usually achieved by the age of 20 months. And then the child can kick the ball when she or he is 2 years old. Let's talk about the social development of the toddler. First, parallel play is prominent from the age of 2 years to 3 years. We have different types of play in children. We have parallel play, cooperative play, and imaginary play. Parallel play means that if you place two toddlers next to each other, they will play on their own, but they won't interact with each other. So they play in parallel. That's why it's called parallel play. Cooperative play, which is achieved a little later, is when they cooperate while playing. To say it simply, they play together. And then imaginary play is when the child plays with his or her imaginary friend. And we'll talk about this later. Okay, now there is another important concept which is characteristic of the toddlers. This is rapprochement. Rapprochement is when the toddler moves away from the parent and then gets back to the parent. And this usually happens at the age of 2 months. The core gender identity is typically established at the age of 3 years. As for the verbal and cognitive development of a toddler, well, by the age of 2 years, the toddler should be able to use anywhere from 50 to 200 words. Like 2 years, 200 words. And then the toddler should be able to say approximately 300 words by 3 years. So more than 300 words. And again, 3 years, 300 words. And finally, let's talk about the preschool child. Preschool age is anywhere from 3 to 5 years. And the child at the age of 3 years can ride the tricycle, which is the bicycle with 3 wheels, right? So 3 wheels at the 3 years. At the same time, the child can paint the stick figure of a man at the age of 4 years. As for the gross motor development, the child can hop on one foot by the age of 4. And if you take a close look at this, the number 4 looks like the two legs, and one leg is elevated and the other leg stands on the ground. And this is how you can remember that the 4 years is the age at which the child can hop on one foot. Now, using the buttons and the zippers and being able to groom himself or herself is usually achieved by the age of 5 years. Now, let's talk about the social development of the preschool children. Preschool children, by the age of 3 years, should be able to spend the certain part of the day comfortably away from the parent. They still have separation anxiety and they still have stranger anxiety, but they should be able to stay without their parents for some period of time. And then, as we already mentioned, after parallel play, there comes the cooperative play and imaginary play. Cooperative and imaginary play is usually achieved by the age of 4 years. Now let me take a step back and talk to you about the imaginary friends. Having imaginary friends is totally normal for a preschool aged child. The child may speak to the imaginary friend, may play with the imaginary friend, and sometimes the parents are anxious or even terrified about this behavior because they think that something is wrong with their child. It's very important to know that having imaginary friends is the normal part of the development. This is not the visual hallucination, this is not delusion, and this is not psychosis, the manifestation of psychosis by any stretch. This is the normal part of development. Therefore, when the mother brings the child and reports that the child has an imaginary friend whom he talks to or plays with, the physician should most likely reassure the parent that this is the normal phase of the development. Okay, and finally, let's wrap up this table by talking about the verbal and cognitive abilities of a preschool-aged child. By the age of 3 years, the child, as we already mentioned, should understand more than 300 words, and even more. Usually, by the age of 3 years, the child understands 1,000 words. And the age of 4 years is the time when the child can properly use the prepositions in the sentences, and they can tell the detailed stories at the age of 4 years. Okay, this was the normal infant and child development. Again, that wasn't thorough, but we covered it in detail in the PEDS section. And now, let's talk about the infant deprivation and the effects of the infant deprivation. The infant deprivation means that the guardian deprives the infant from the care, love, and affection that the infant needs for the normal development in the future. And it may seem logical and apparent that the infant needs love and affection from the family, but I think it's still worth mentioning that when the infant does not have that affection and care from the family members, or at least from the guardians, this can have very drastic and serious consequences in the infant's development. First, infant deprivation may cause failure to thrive, which means that the infant does not gain weight normally, gain height normally, doesn't develop normally in terms of the social and verbal development. Again, the infant learns everything from interaction with the people. If people doesn't talk to infant, then the infant will likely have the poor socialization and the language skills. At the same time, leaving the infant unattended in the first few months of life can actually result in the basic mistrust to all people. And it's very important. So The first few months, approximately 6 months of life, is the critical period for the child's development. And if the child is kept unattended and not cared enough during these first 6 months, this can cause the child to have the basic mistrust and the difficult relationships later in the future on. The infant deprivation can have several consequences as well. In consequences, here I mean the psychiatric diagnosis that stem from the infant deprivation. And there's a spectrum of what can happen to the child who was deprived of love and affection in the infancy. But let's talk about the two extremes of this continuum. We have reactive attachment disorder and we have disinhibited social engagement disorder. So RAD and DSED. Reactive attachment disorder is when the child becomes absolutely unresponsive and absolutely withdrawn to any type of comfort in the future. Since the child is not used to comfort and love and affection in the infantile period, then he or she doesn't know what love and affection actually means, and therefore he stays cold and distant and totally unresponsive to the comfort. This is reactive attachment disorder. This is reaction to poor attachment to the guardians or the parents in the infantile period. The disinhibited social engagement disorder is the extreme opposite of the reactive attachment disorder. And actually the name tells us everything that we need to know about this disease. Disinhibited social engagement disorder. It means that the child who has had infant deprivation engages in the social relationships in an absolutely disinhibited manner, which means that this child can attach to the strangers indiscriminately and very, very easily. And this can be very dangerous because the child establishes very close relationship with the strangers very fast, and some people may take advantage of this. So again, leaving the infant unattended and keeping the infant deprived can have absolutely destructive consequences for the child in the future. And if, again, infant deprivation lasts for more than 6 months of life, that can result in irreversible changes. And finally, if the infant is deprived of all the basic affection and care, then the infant may also die. Right, so now that we've talked about the infant deprivation, let's talk about the child maltreatment. The child maltreatment is divided into two types of maltreatment. We have child abuse and we have child neglect. The most common type of child maltreatment is actually the child neglect. And before we talk about the child abuse and neglect in detail, let me tell you one very important thing. Any type of child maltreatment, whether it's abuse or neglect, is mandatorily reportable. Whenever the physician even suspects that the child is abused or neglected, he or she is obliged by the law to inform the Child Protective Services. Okay, now let's talk about the child abuse first. There are three different types of abuse. There is physical abuse, sexual abuse, and the emotional abuse. And again, all of these types of abuse are reportable. It's not only physical or sexual abuse, but it's also the emotional abuse that should be reported. Let's start with the physical abuse. Physical abuse represents applying the non-accidental trauma to the child. Well, here we're talking about the child abuse, and that's why I'm saying child. However, physical abuse can be unfortunately applied to anyone. And the non-accidental trauma can include anything starting from the burns or bruises all the way to the fractures. Very commonly, these injuries are in different stages of healing. And that's a very important clue in the stem by which they are trying to make you think about the child abuse. The reason for why the different stages of healing may suggest the child abuse is that child physical abuse is usually not a single event. It usually happens over time. Therefore, the previous injuries, inflicted injuries, are usually resolving, and there are the new injuries, right? And so this is why the injuries are in different stages of healing. However, these words, like different stages of healing, are not the buzzwords for the child abuse. And that's a very important point, especially for USMLE Step 2 CK. The idea here is that there may be the other conditions, medical conditions, which may look like the child abuse. And the classic example for here is osteogenesis imperfecta. Osteogenesis imperfecta, just to briefly remind you, is autosomal dominant condition of defective type 1 collagen. And in this case, the bones are very brittle. This is why it's also called the brittle bone disease. And the patients may have several fractures in the different stages of healing. And in this case, definitely it doesn't suggest the physical abuse, it suggests the weak bones. Let's get back to the physical abuse. The infants, especially infants, commonly experience something called the abusive head trauma, also known as the shaken baby syndrome. We also talk about the shaken baby syndrome in the pediatric section. However, let's remind ourselves what this is. This is exactly what it sounds like. The caregiver shakes the baby violently and uncontrollably in order to calm the baby. And when you shake the baby violently, well, there are several consequences. First, this exerts the pressure and tension on the bridging veins, which are between the dura and the arachnoid mater in the brain. Therefore, tearing of the bridging veins can occur, resulting in the subdural hematoma. At the same time, violently shaking the baby exerts the tension on the retinal vessels. So retinal vessels can rupture, and the patient may exhibit the bilateral retinal hemorrhages on the fundoscopy. And finally, when the caregiver holds the baby with the trunk, then the pressure exerted by the caregiver's fingers on the posterior ribs can cause the posterior rib fracture. Again, the three classic signs of shaken baby syndrome include bilateral retinal hemorrhages on fundoscopy, subdural hematoma on non-contrast CT, and the posterior rib fractures from excessive finger pressure. Right. And in the physical abuse, and generally in any type of abuse, the caregiver might actually delay seeking the medical attention for the child. And that's logical because caregiver is guilty in inflicting these injuries to the child, and he or she knows that if he or she seeks the medical attention for the child, then the situation will most likely be uncovered, and this will definitely be followed by the legal measures. Okay, another thing that caregivers of the physically abused child do is that they make up with the stories that don't coincide with the child's developmental stage. And if you remember, I've already told you one example of this. For example, if a 2 or 3 months old infant comes with the bruise on the head and the mother says that the infant rolled over on the bed and fell onto the floor, that's almost impossible because the ability of rolling over and sitting is achieved by the age of 6 months. This is how you can suspect that the child may be abused. At the same time, very characteristically, the caregivers of the abused children commonly change the stories during the same visit. So at first, they might say that the child, I don't know, fell off from the height and this is how he inflicted this injury, but then After further repeat questioning, the caregiver may say that the child fought with his other child, so his brother or sister, and this is how he inflicted these injuries. And we should know that the 40% of the deaths caused by the child abuse or neglect usually occur in the children less than 1 years old. To say it in other words, infants or children less than 1 years old are especially vulnerable and susceptible to the child abuse because they are small, they are vulnerable, and they cannot communicate their concerns and their stories to the physicians. Okay, let's move on to the sexual abuse. How can we suspect the sexual abuse? Well, when the child has either sexually transmitted disease or the UTI or genital or oral trauma, all of these signs suggest the sexual abuse. Now, let me take a step back and explain something. When the child, let's say, when the child presents with the UTI, this does not mean that the child is sexually abused. Like, this does not guarantee by 100% that we're dealing with the sexual abuse, because child may have some anatomical defect in the renal collecting system that predisposes to the frequent UTIs. But again, we should consider the whole case with all the characteristics, and if we see UTI, the previous history of STI, or on the physical exam we discover the genital trauma or the oral trauma, then all of these signs and symptoms together create the picture of the sexual abuse. Usually, when the child is sexually abused, there are no physical signs of injury. And definitely, and this means that sexual abuse should never be excluded from our differential in the absence of physical trauma. The absence of physical trauma does not mean that the child is not sexually abused. Another common clue by which we suspect the sexual abuse is that children who are sexually abused often have the sexual knowledge or the behavior that's absolutely inappropriate and incongruent with their age. We'll talk about more about this matter later in this lecture, but again, so if the child has a very advanced sexual knowledge, that's not completely normal, and that can definitely suggest the sexual abuse. The peak incidence of the sexual abuse usually happens from 9 to 12 years of age, and usually sexually abused children are the girls. And the abuser, in case of sexual abuse, is usually someone who is known to the family. It's usually a male who is known to the family, but who is not the immediate part of the family, who is not the family member. The physical abuse, in contrast, is usually inflicted by the family member. Usually it's the caregiver. Okay, and finally, we have the emotional abuse. Emotional abuse presents differently in the different ages. If we are dealing with the baby or the young children, like 2 to 3 years old children, they usually lack a significant bond with the caregiver, and they can establish a very close relationship, an affectionate relationship with the less familiar adults. Let me give you an example for this so that you never forget what I'm talking about. As we already mentioned in this episode, children start to develop the stranger anxiety and separation anxiety at the age of 6 and 9 months, respectively. Now, let's say that we have a 1-year-old boy who is brought to the physician for a regular checkup, and you observe that the child does not start to cry when the physician tries to examine him or her, and it doesn't feel like child is meeting with a stranger. And in contrast, the child is willing to come close to the physician and to get to know to the physician, but the child is not interested in the caregiver. This may give us the clue that the child may be the victim of the emotional abuse. And these children are usually aggressive towards the other children, and also the animals, and they might be very, very anxious as well. When we deal with the older children who are emotionally abused, they are very labile emotionally, and therefore they might change their mood very rapidly, and they may actually have the angry outbursts too. Older children calmly distance themselves from their family and the caregivers, and at the same time, they might have the somatic symptoms which are unexplained by another medical condition. Somatic symptoms like headache, or diffuse pain in the body or fatigue. These are the symptoms of somatic symptom disorder. And we'll talk about somatic symptom disorder later in this course. Emotional abuse is not less severe than the physical or sexual abuse. And let me give you the proof for this. Approximately 80% of the adults who were the victims of the child emotional abuse meet the criteria for at least one psychiatric diagnosis by the age of 21. Again, this proves that emotional abuse creates a very long lasting, often lifetime effect on the child, and it can be detrimental to the child's mental health and the physical health as well. Right, now that we have talked about the all three types of child abuse, let's talk about the child neglect. The child neglect is exactly what it sounds like. The caregiver neglects the child completely. And child neglect is actually the most common type of child maltreatment. It means that the child is devoid of the adequate shelter and the food and education and love and affection that every child deserves. So, child neglect means that the caregiver just violates all the basic human rights and the child rights, so that are necessary for the child to grow normally. And there are many, many different signs by which child neglect can be suspected. If the child is inadequately fed, then the child will be malnourished and the child may exhibit the failure to thrive. And if the child is not bathed and is not dressed appropriately, then we will be able to observe the poor hygiene. And again, if the child is devoid of the love and affection, then the child will be very distant and cold emotionally. Well, child neglect is not the same as the infant's deprivation, and the main difference here is the child's age. Infant deprivation is the deprivation of all of these basic human rights in the infantile period, meaning in the first year. And infant deprivation can have much more serious consequences than child neglect, because again, that first 6 months of life is the critical period for child development. But child neglect happens after the age of 1 year, and it can also present with the similar signs and symptoms. Again, as we already mentioned, child neglect is just as reportable as any type of child abuse. What I'm trying to say here is that doing something harmful to the child is just as bad as not doing good to the child. And again, child neglect must be reported. The next topic in our today's episode is the vulnerable child syndrome. The vulnerable child syndrome is when the child is perceived to be weak and vulnerable by the parents. The parents think that the child is vulnerable and susceptible to the different diseases and the injuries. And this usually happens after some serious life-threatening event or trauma to the child's life. And in some sense, and in some at some point it makes sense. For example, if the child has had leukemia and he got cured from leukemia, then the parents are overly sensitive and overly anxious about the child's health, and they think that they should excessively take care of the child. And this can result in like missed school days, overuse of the medical services, But vulnerable child syndrome is not the same thing as factitious disorder imposed on the other, or Munchausen syndrome by proxy. We'll talk about Munchausen syndrome by proxy later in this course, but still, I'd like to make a distinct line of difference here. Vulnerable child syndrome is when the parents perceive the child as very vulnerable and susceptible to the illness or injury. They are overly protective and overly anxious about their child's well being. In case of the factitious disorder imposed on the other, also known as the Munchausen syndrome by proxy, the caregiver, whether it's the biological parent or not, makes the child sick in order to get some kind of gain. So, more on the Munchausen syndromes later in this course. So this was the vulnerable child syndrome, and vulnerable child syndrome is not the problem of only the parents. It's the problem of the child as well, because when the parents are overly sensitive and overly protective for the child, then the child may have emotional disturbances in the future. The child may actually develop the dependent personality disorder in the future. So again, this is a serious problem, and the patients with vulnerable child syndrome need the psychosocial support, and their parents also need the psychosocial support. Right, now let's move on to the assessment of the intimate partner violence, or IPV. Here, as we are going to talk about the intimate partner violence, we are not talking about children anymore. We are talking about the adults who are abused by their intimate partners. And first, let's talk about the signs of the possible intimate partner violence. First, there might be the different injuries on the body. There might be injuries on the genitalia, or the torso, or the face, or the head and neck. In other words, the patient may be physically and sexually abused by the intimate partner at the same time. At the same time, when the patient comes to the physician and the physician confronts him or her about the injuries on the body, then the patient may come up with some inconsistent explanations that they fell off. I don't know, they fell off, or something happened to them, like car hit them or something. They are very evasive, so they try not to talk about these trauma, and they are also fearful. People who are abused by the intimate partner are usually non-adherent to the follow-up. The reason for this is that they are afraid of the fact that like the physician may find out about the intimate partner violence, and they are afraid that if the intimate partner finds out that the physician knows about this, they may get hurt even more. Like patients who are abused by the intimate partner always, not always, but frequently come to the emergency department due to some acute medical condition, for example, bleeding or bruises, or etc. And these patients may actually be accompanied by their intimate partner. And if they are accompanied by the intimate partner, the partner usually resists the patient being seen alone. And that also makes sense. If the person is an abuser, then he or she makes sure that their partner, abused partner, is not seen alone, and that partner does not disclose the facts of abuse to the physician. At the same time, when the physician examines the abused patient, there may be much discomfort during the physical exam, and even a slight touch, the regular touch from the physician, may induce severe anxiety in the patient. Also, the patient may have a frequent history of the STDs, and they may also have the chronic pelvic pain. Actually, chronic pelvic pain is very common in abused individuals. Now, how do we interview the patients who are probably the victims of the intimate partner violence? Well, the first and foremost, we ensure their privacy. Although their intimate partner might not want us to talk to the patient separately, we still should talk to the patient separately to find out more about their condition and to help them to our best capabilities, right? And when we talk to the patient with the intimate partner violence, we should try to stay absolutely non judgmental and very empathic because it's not their fault that they are abused, right? And we don't know anything about the history of this patient, and therefore it's better to stay non judgmental. Not only in this situation, but in any situation, in any medical complaint that's unacceptable for us. Open ended questions are very important for the patients who are possibly the victims of the intimate partner violence. This is because we need them to talk and we need to find out more about their condition. Very importantly, although the child and elderly abuse are mandatorily reportable, the intimate partner violence and the adult abuse is not mandatorily reportable. So we do not have the right to pressure the patient to leave the partner or report the partner or to disclose the abuse. It is their responsibility and it is their choice. But what we are absolutely responsible for is that first we need to assess their immediate safety, and we should ask if they have their emergency safety plan, if they have the place to go in case of emergency. And if they don't, we should provide them with all the referrals and all the information that they need, so including the shelters, including the mental health clinics or the domestic violence agency. So again, when we talk about the intimate partner violence, there are three main important things during the interview. Interview should be held with keeping the patient's privacy. We should be non-judgmental and very empathetic, and we should provide the patient with the knowledge and the help that we can. Right, now let's move on to the sexual assault. Here we will talk about how to manage the patient who has been the recent victim of sexual assault. First, we need to perform the detailed physical exam, and forensic examination should also be performed to find out if there is hair of that patient, not patient, but of the person who sexually assaulted our patient, or if we can find the semen so that the DNA analysis can identify the sexual abuser. But at the same time, psychological assessment is very important in the victims of this sexual assault. The reason for this is that there are several consequences of the sexual assault. Very commonly, the victims of sexual assault develop the mental health disorders like PTSD, which is a lifelong condition, and it's very, very challenging and distressing for these patients. Other than PTSD, the sexual assault can result in unintended pregnancy or the sexually transmitted infections. And these points are very important in terms of how we need to manage these patients. First, we need to give them the post-exposure prophylaxis for, let's say, HIV. Also, we need to cover Neisseria gonorrhea and chlamydia by ceftriaxone and azithromycin. We need to cover Trichomonas vaginalis with the metronidazole as well. Emergency contraception is very important, again, to avoid the unintended pregnancy, and this can be the intrauterine device, this can be the progestin pills, or even anti-progestin pills like ulipristal. And again, psychosocial counseling. So psychosocial counseling is the cornerstone of the evaluation and the management of the victim of the sexual assault. And please don't forget about the consequences, and don't forget about the post-exposure prophylaxis and the emergency contraception. Okay, and the last topic that we'll talk about in this episode is the sexual behavior in preadolescents. It's very important to know that there is the normal sexual behavior in the toddlers and the school-age children, and then there is abnormal sexual behavior in any age in children of any age. Let's talk about the normal sexual behavior in the toddlers. Exploring one's own genitals or the others people genitalia is actually normal because toddlers and toddlerhood is the age by which the core gender identity is established, and this is when the child understands the tries to not tries but starts to understand the difference between the male and female physiologic gender. Toddler may actually express the masturbatory movements as well, and is also considered to be normal. And undressing self or the other people is also normal. Now, when we talk about the school age children, they have increased interest in the sex words and play, and they commonly ask the questions about the sex and the reproduction. And also, they may exhibit the masturbatory movements, which is also normal. Now, there are several, there's abnormal sexual behavior, which is common for children of all ages. First, if the children is observed to repeatedly insert the object either into the vagina or the anus, this is clearly abnormal, and this may indicate that the child may be sexually abused. Also, if the child involves in the sex play, which involves either genital to genital contact or oral genital contact or the anal genital contact, this is abnormal for children of both toddlerhood age and the school age. If the child uses the force or the threats, or if the child bribes the other person in the sex play, this is also abnormal. And finally, if the child has age inappropriate sexual knowledge about the reproduction, about the sexual practices, this is also clearly abnormal. The reason for why this information is very high yield is that sexual behavior in certain sexual behaviors in pre-adolescents and school age kids are totally normal, and we need to be able to differentiate the normal from abnormal sexual behavior. Okay, now we've discussed multiple different topics across the psychiatry, and let's summarize everything that we've discussed today.